connect this now, the mic, or do you want to wait? It's whatever works best for you. Okay. Sometimes people keep the mic away. Thank you. And like I said, some of the hospitals sometimes will pop on, but we usually have a few people streaming. I appreciate it. Thank you so much. No problem.
Check, check. Is it on? Sound test. Is that okay?
Sounds good.
Good. Yeah, you're welcome.
Thank you.
No problem. Bo. Hey, Bo. Who's with Thomas today? Who's with Thomas today? Okay. Taking out Lane's daughter's gallbladder. Don't mess it up.
You've got to introduce your name.
Okay.
I think you have the mic, right?
Does that mic not work?
Oh, it does. Do you want to walk around?
Yeah, I've got it this morning. Go ahead, James. We're turning the lights down.
You ready to roll?
Yeah.
Dare you to do an impression. Double thing.
All right. Can everybody hear me? Yeah, all right. So our speaker today is William Wiley. We'll be speaking on severe sepsis and septic shock, the early sepsis bundle. The program's underwritten by an educational grant through the OSU Medical Center Graduate Medical Education. A disclosure statement's been signed and is on file in the GME office. So, Dr. Wiley's did an osteopathic internship at St. Anthony Hospital in Oklahoma City and emergency medicine residency at Integra Southwest Medical Center in Oklahoma City. He's currently the program director here at the OSU Medical Center. So please welcome Dr. Wiley.
Thank you, sir. Can everybody hear me okay in the back? All right. I think I'm supposed to say something about how I don't have any financial conflicts. So let's get started. This lecture is part of our CLEAR. Most of you guys who are in residency programs have probably heard about the CLEAR initiative that's part of the new ACGME accreditation process. I gave this lecture to my residents about 2 weeks ago. They fell asleep about halfway through it, so I took out about half the slides. So hopefully you guys can stay awake through this. So some objectives. We're going to go through the spectrum of sepsis. We're going to talk about the evidence, a few major studies, and a little bit of detail. We are going to speak on the National Quality Forum and the Surviving Sepsis campaign. And then lastly, we're going to bring it home with talking about the new sepsis inpatient quality measure for CMS, a.k.a. how we get paid. So unbelievably, in 2015, we're still using the SEERS criteria when we talk about sepsis. And most of the world has since moved on and long declared SEERS to be dead. But in the United States, it's on life support, if you will. It's been around for 20 years, and all talks on sepsis have to begin with this because it's part of defining sepsis. So when you look at what consists of the SEERS criteria, you have temp, either high or low, heart rate only greater than 90. So tachycardia is defined as heart rate greater than 100. So a lot of people miss this because they think if it's in the 90s, you're okay. But actually, once you hit 90 and above, you're in SEERS criteria. Respiratory rate, which is notoriously the most inaccurate of all vital signs, basically because it's physically impossible to sit there for a minute and count someone breathing. Most nurses will do this for about 5 seconds and multiply it by 12, or 10 seconds and multiply it by 6 if they're bad at math. Or if you have capnography, their CO2 is less than 32. And then the last part of the Sears criteria involves the white blood cell count, either less than 4, greater than 12, or greater than 10% bands. So there's lots of issues with Sears, and we're going to go into that a little bit of detail in just a second. But as it stands, this is what we have to work with. So what do we care about Sears? Well, the Sears criteria are used to make a diagnosis of sepsis. So the diagnosis of sepsis is a presumed or suspected infection. You don't have to have a documented infection to be septic, but you have to have a presumed infection, and you have to have at least 2 of the Sears criteria. Moving down the spectrum to severe sepsis, that is defined by a lactate of greater than 4. So lactates, it's kind of interesting when you look at the history of lactic acid. Back when I was a student and a resident, we were taught that elevated lactates were bad because it was a product of anaerobic metabolism due to end organ ischemia. But now there's some thought that lactic acid is generated by the patient's own endogenous epinephrine, causes glycolysis in the skeletal muscles that generates too much pyruvate, and the byproduct of that will be an elevated lactic acid. And it may not be as bad. Regardless of whether you believe one of those, both, neither, it's still thought that an elevated lactate is probably badness. So I'm okay with that. We're going with that. Hypotension. So on down the spectrum, if the patient's hypotensive, then they fall into the category of septic shock, but only if their blood pressure remains low, meaning a systolic blood pressure less than 90 or a mean arterial blood pressure less than 65 after the initial fluid bolus. So this part is key, that after there. Because a patient who rolls in who's sick, who's septic, and hypotensive does not meet the criteria for septic shock unless they remain hypotensive after that initial fluid bolus. So these are pretty much the classic definitions that have been around forever and the basis of most of the literature involving sepsis, and we're going to go through those studies shortly. But these are all pretty much common definitions that you all will need to know. So I mentioned the SIRS criteria. Like I said, most of the world has moved on. The issues with the SIRS criteria are legion, and this article that was published earlier this year, I believe in April, kind of goes through the problems with the SIRS criteria. And just a few of the key points are the terminology does not help us understand the underlying problem. A sepsis patient, a hypotensive septic patient who has severe sepsis has much more going on than just an inflammatory response. It's been around for 20 years and it's hanging in there. There's lots of new criteria out there. There's multiple. There's a common one used in Europe called the SOFA criteria that deals with organ failure, and it has much more clinically relevant things such as hypotension, altered mental status, tachypnea, things that you can actually look at the patient instead of checking a bunch of labs. Patients can have severe sepsis without meeting the SIRS criteria, so it doesn't help you in those patients. It's too sensitive, but it's not specific. So there's studies where they look at ICU patients, and sometimes up to 80% of them can meet SIRS criteria, but they don't have an infection. Obviously, those patients would not benefit from getting a broad-spectrum antibiotics and will likely cause them harm. During flu season, when we are inundated by everybody coming in with a fever of 102 and body aches, and they might have a heart rate that's above 90, all those patients are technically fall into the category of sepsis because they have the flu, they have a fever, they have a heart rate of 91, and we don't do anything for those patients. Some people like to give Tamiflu, whether you believe that works or not, but most of the time we give them something for the pain, give them some Tylenol, tell them to push some fluids, and we don't check any labs, we don't give them any antibiotics. So it's highly sensitive but not specific. And lastly, the SIRS criteria doesn't reflect the severity of the disease process, meaning it's not cumulative, it's not predictive. Patients that have 4 of the SIRS criteria aren't found when they study it to be any sicker than patients that have 2 of the SIRS criteria. However, after mentioning all these things, we're still stuck with it, so moving on. So why do we care so much about septic patients? Well, this is an old chart, and it really hasn't changed that much, but if you look at the spectrum of sepsis and 28 mortalities, it's pretty impressive. Interestingly, the mortality goes down a little bit for patients that meet SIRS versus don't meet SIRS, but once you hit severe sepsis, it shoots up, and once patients start going into shock, they start dying at a rapid rate. So it's really important that we take good care of these patients and try to do the best according to the evidence. And as you might imagine, as you start involving more and more organs failing, your mortality rates climb significantly. The other issue with sepsis care in this country is cost. It is the single most expensive condition treated in the United States at $20 billion a year. And this was from 2011, so those numbers have since gone up. Lots of septic patients costing lots of money. The cost has quadrupled since 1997, and it goes up about 11% annually. So it is incredibly expensive to take care of these sick and dying patients. In Medicare and Medicaid, it's the first and second most costly condition billed to them, aka CMS, who pays for all these patients. So they want to make sure that we're doing everything that we can, according to the evidence, to take the best care of these patients. It's very expensive for the private insurance as well. So the landmark study for sepsis care happened in 2001 with early goal-directed therapies. Anyone ever heard of this, EGDT? Probably not. Well, before 2001, the way we took care of septic patients was, if we thought they had an infection, we gave them some antibiotics. If we thought that if they were hypotensive, we gave them some fluids. In 2001, this guy named Manny Rivers out of Detroit General Hospital in, Henry Ford Hospital in Detroit, who was a critical care doc, said by the time these patients are getting to the ICU, we're already behind the 8 ball. The concept of goal-directed therapy had been around in critical care for a long time. He put this word in front of it that said early. He said, I want you guys in the first 6 hours in the emergency department, when these patients hit the door, to start doing some tasks, like getting a lactate. I want you to put in a central line so you can measure a CVP. I want the CVP to be at least 8 to kind of fill up the tank from a fluid resuscitation standpoint. Then I want you to draw a gas, central venous oxygen saturation, out of the central line, and I want that to be at least 70, with the concept behind that being if the O2 sat is less than 70, then you have too much ischemic end organs extracting too much oxygen, and we need to get more oxygen to them by either transfusing if their hemoglobin was less than 10, or giving dobutamine for a low ejection fraction. So now we had all these tasks and boxes that we had to check in the emergency department for these septic patients, and we had to get all this done within the first 6 hours of them hitting the door. Obviously, we continued to get blood cultures and give antibiotics as we generally had done before, and give them fluids if they were hypotensive. So when this study was published in 2001 in the New England Journal, it was pretty impressive. Small study, only 263 patients, but they found an overall absolute 16% in-hospital mortality for the septic patients who were on the study arm of this study. So this was pretty impressive. And around this time, a surviving sepsis campaign was born. And the lead author, Manny Rivers, of this study started making a tour around the country. And he actually came to my hospital in Oklahoma City, where I was a resident, at a setting similar to this at a grand rounds. But it was all staff, attending physicians, surgeons, critical care, ID, ER. And he said, listen, this is my study. Everyone in the country is going to this. This is what you guys start needing to do. It works. It saves lives. So this is what we did. We initiated a sepsis bundle, and as a resident, it was awesome because I put in like 8 lines a day. I was flying all over the place. That's all I did was put in lines. And we're checking CVPs. In their study, they had a catheter. I don't remember the name of it, but it was a continuous mixed venous central O2 saturation catheter that gave you a constant number. We would just draw the gas out of the central line and run an ABG on it to get ours. And it was the same thing. And we did it while I was there during my residency. And then whenever I got out and went to St. John's, shortly after I started there, their intensivist said, hey, we're not doing this. We need to start doing it. So they came down to the ER and they said, hey, when you guys have a septic patient roll in the door, you call the critical care service, and we're going to come down at the bedside, and we're going to put in the lines. We don't trust you guys. You guys are going to screw this up. We're going to do all the things that we need to be doing, and we're going to start saving septic patients' lives. And that lasted for about 6 months until flu season hit. Then I'd call them up and say, hey, I got a patient. They're like, oh, we're too busy. Can you put that line in for me? So regardless. So did we actually get it to work? I'm not sure, but we did put in a lot of lines. I'm sure I caused some line-induced infections and clots, and I dropped one lung. You haven't put enough lines if you haven't dropped a lung yet. So. But did it actually work? We've been wondering this the whole time. Is this really as good as they say it is? Well, finally, within the last year, we've got 3 major studies, the PROCESS trial, the PROMISE trial, and the ARISE trial, that were all also published in the New England Journal of Medicine, and they all compared early goal-directed therapy versus standard care, meaning give fluids, get cultures, give antibiotics, but you don't have to check all these boxes and take all these measurements and transfuse people. And what do they all find? No mortality benefit at hospitalization, 60 days, 90 days, or 1 year. So that basically was the nail in the coffin for early goal-directed therapy, and that's probably why you guys haven't heard that much about it, is because it probably didn't really work, and now we have the studies to prove it. So that's a little bit of the history of the major studies involving the care of sepsis patients. So what have we learned? What do we know that works in sepsis? Well, recognize potential septic cases early and follow them closely. Duh, right? If you have a really sick patient, you're probably going to pay very close attention to that patient. The lactate can be helpful in the occult septic patient where they don't look that sick, but you get a lactate level on them because they've got a fever and they've got a pneumonia and their lactate comes back at 8. And usually that is the younger, healthier patients with fewer comorbidities that can tolerate their blood pressure a lot longer than an older, sicker patient. Give fluids. How much fluids? Nobody really knows. Most of the patients that in those last 3 Holy Trinity studies of sepsis got around 2 liters in the first 6 hours. So probably somewhere around there. It's actually getting controversial now whether hypotensive septic patients are actually volume depleted. There's some experts out there that say that in a septic hypotensive patient, all that fluid is pooling in a dilated venous system. And if you just touch them with a little bit of a pressor, which pressors work first on the venous side before it causes arterial constriction, you can bring their blood pressure up and not have to pour fluids in them and then cause them to third space and cause significant amount of edema. But that's a debate for another day. Lastly, give antibiotics as early as possible. Notice I don't have a time frame on there. We're going to talk about that in just a second why. But as early as you can. What doesn't work in severe sepsis and septic shock patients? Checking CVPs, checking central venous O2 sats, giving blood for anemia, which, as we've also learned in things like GI bleeds, patients do worse when you give them blood. There's something about transfusing blood that causes patients to do worse. Be careful about giving transfusions unless someone is bleeding out in front of you. Dobutamine and trending lactate levels. The initial lactate level can be helpful. Because we don't really know how exactly lactate works and it may be beneficial, you should definitely be treating the patient and how they are improving more than treating a trending lactate level that may be increasing while a patient is getting better clinically. Moving on, so National Quality Forum. Has anyone ever heard of this? I hope not. I've never heard of this before I gave this lecture. There's way more important things for you guys to be learning about than this. But this is a body that likes to make guidelines. And most of the guidelines that they make are very quickly adopted by the CMS for their quality measure guidelines. CMS has National Hospital Inpatient Quality Measures. And if you don't do what they tell you, then you don't get paid for the care of that patient. So that becomes very important for reimbursement. And as you may have noticed, our facility takes care of a large number of Medicare and Medicaid patients, and we need to maximize our reimbursement on those patients. Since 2012, the National Quality Forum has been pushing their question number 500, which involves severe sepsis and septic shock. Typically, once they develop their guidelines, it's very rapidly moved into a quality measure. But this one has been having lots of issues getting approved and has been pushed back, obviously, for 3 years. And it was initially supposed to go live this January, but it's now pushed back to this October. And where did this National Quality Forum get their recommendations for their sepsis bundle? They got it from the Surviving Sepsis campaign. As I previously mentioned, when our first early goal-directed therapy study came out, and we all said we need to start doing this, Eli Lilly, decided that they were going to fund and promote the Surviving Sepsis campaign. Now, it was primarily so they could sell Zygris, which was a medication, activated protein C, that was very expensive. It cost $20,000. And you gave it to the patient who was incredibly sick right before they died, and it caused them to bleed out of all their orifices, and then they died much faster. It was then taken off the market in 2011, but the Surviving Sepsis campaign survived. So what are their recommendations? And I don't know what happened here. Fortunately, it's on another slide. But we'll talk about this. So here's what their recommendations are currently. Within 3 hours of time and presentation, they want you to get a lactate level. They want you to get a blood culture prior to the antibiotics. They want you to administer broad-spectrum antibiotics. And then I believe this is going to say if the patient's hypotensive, they want you to give them fluids within 3 hours. The next part of this bundle is to be completed within 6 hours. They want you to give pressors if they remain hypotensive within 6 hours. If they don't respond, if they're persistently hypotensive after the initial fluids, they want you to reassess by doing a volume status and tissue perfusion exam. And we'll talk about that in just a second. And then lastly, they also want you to remeasure a lactate if the first one was elevated. So we kind of already talked about which of these components is beneficial and which isn't, but this is what they decided they thought was important. As far as the reassessment of the volume status within 6 hours, this is what they were talking about. You can either go see the patient and just do an exam by a licensed independent practitioner, meaning the physician. Sorry, interns, you don't have a license, but they want you to check the vitals, do a heart and lung exam, do a cap refill, check a pulse, and check their skin. That's all you have to do. Or, if you don't want to get up and go see the patient, you can do some things that we know don't work. You can have the nurse run a CVP, check a central venous O2 sat. You can order a bedside echo, or you can do these other physical, but you have to do 2 of these. So one of the main reasons that the core measure has been pushed back is because initially the CVP and central venous O2 sat was part of the things that you have to do within 3 hours. But several physician groups, including the American College of Emergency Medicine, came in and said, hey, we just had 3 major studies that showed this doesn't work. We're not doing it. Don't make it required. But they just couldn't let it go. So they had to put it in on this part, but you still don't have to do it if you're willing to get up and go see the patient. There's a few other recommendations to briefly mention from the Surviving Sepsis campaign. The first one being fluid of choice is crystalloids. Pressors, they like norepi or levofed. They also like epi. And then you can also add some vasopressin if you're getting a little too high on those doses. They don't like dopamine. Pardon me, wrong button. They don't like dopamine because of the tachyarrhythmias associated with it. And neo, really not recommended. So those are a few of the further recommendations for Surviving Sepsis campaign. Now, this is what we're here for. So specifications for National Hospital Inpatient Quality Measures starting October 1st, 2015, a little over a month. So these are all the things that you guys talk about when you have your department meetings and the quality people are there about whether or not you're meeting your core measures. When we have ours, there's several things that we look at, such as door-to-doctor times, door-to-discharge times, aspirin on arrival for chest pain, EKG on arrival for chest pain, AMI. There's certain things that the cardiology service follow. The surgical, I'm sure they have their own things. But now we've got severe sepsis and septic shock, and those are going to start being tracked in October. So what shall they have us do? Well, here's the data set. There's 63 components. It looks long, but really most of them are doing it, dating, and timing it. So initial lactate level, date, time, result. Blood culture, collection, broad-spectrum antibiotics. What else is up there? Septic shock present, severe sepsis present, and time. There's 2 different entities, remember. You have severe sepsis and septic shock. And here's what their bundle looks like. And if you were paying attention to the previous slide involving the Surviving Sepsis campaign, it's essentially the exact same thing. So CMS will have us check a lactate level, get antibiotics going after the blood cultures in the first 3 hours. Within 6 hours of severe sepsis, they want us to remeasure the initial lactate level. If they're hypotensive after the initial fluid bolus, they want us to start pressors. If they're initially hypotensive, they want us to give fluids within 3 hours, start pressors within 6 hours. And then here's that repeat exam that I just spoke of within 6 hours that you need to repeat or do these things if they have a central line. Who does this involve? All patients who are 18 or older that end up with a discharge diagnosis of sepsis, severe sepsis, or septic shock, and who can be excluded from this data set. Well, here's the excluded population. Anybody that gets placed in comfort care within 3 hours of severe sepsis, anyone that gets placed in comfort care within 6 hours of septic shock, administrative contraindication to care, I'm not really sure what they mean by that. I love this one, length of stay greater than 120 days. I would love to have been on that committee. If you're here for 119 days, let's make them do it. If they're here for 120 days, they don't have to do it. Hopefully no one's here that long. Anyway, this is going to be good for us. Transfers in from other acute care facilities. So we get lots of transfers from other hospitals now of really sick patients. Those people aren't going to be involved in this data set. Patients with severe sepsis who expire within 3 hours. So if they die, they don't within 3 hours, then they're severely septic. Or if they're in shock within 6 hours, they're excluded. So these numbers are going to start being tracked in a little over a month. So it's really important that we're compliant. I kind of mentioned it briefly, but time of presentation here is going to be key because unlike most core measures that we have to deal with in the ER, this also applies for you guys up on the floor. And there's 2 clocks running, so there's lots of tasks that have to be done and checked off. There's no partial credit. You can't just do a few of these things and not do all of them and get full credit for the reimbursement. And a lot of these patients are going to be transferred around the hospital from the floor to the ICU, from the ER to the ICU, and it's going to be really important that we are communicating on what has been done and what needs to be done. And like I said before, a lot of your patients that might be directly admitted or may not have been that sick when they first came in and then go into severe sepsis or septic shock will also be included in this data set. I've spoken with the people at the quality department, and they're currently working on some physician order entry stuff for Meditech. We have lots of order sets already in the emergency department that make things real nice so you don't forget what you're supposed to be doing. And they are working to get these ready for the October 1st go live date. They're not ready yet, but you'll be hearing more about this in the weeks to come. And as it stands now, the order sets are likely to be specific either to emergency department patients or patients coming in from the floor. That's really all I have. Does anyone have any questions? All right, thanks, guys. That's it.